Welcome back to chapter 17. We're in section 17.3. We're going to look at other endocrine glands outside of the hypothalamus and the pituitary gland. So let's talk about the pineal gland. The pineal gland is part of the roof of the third ventricle. It sits beneath the posterior end of the corpus callosum. This gland undergoes some shrinkage, or what we call involution, after the age of about 7. When you get to the age of puberty, it's going to shrink down by about 75%. It becomes a very tiny mass in the tissues of the adult, but has a very particular function when we talk about hormone release. The pineal gland is going to influence the timing of puberty in humans. It can also play a role in our circadian rhythms. It's going to synthesize melatonin, and that melatonin is what is going to activate our sleep-wake cycles. You can have people that have a particular disorder called seasonal affective disorder that will interrupt these circadian rhythms. We're not producing enough melatonin, or we're producing too much melatonin in most cases. The symptoms here are going to be depression, sleepiness, irritability, and craving of certain carbohydrates. Any kind of exposure to light can be helpful, but 2 to 3 hours of exposure to very bright light can reduce the melatonin levels, which lead to this seasonal affective disorder. This utilization of light to treat this disorder is called phototherapy. The thymus is going to play a role in our endocrine, lymphatic, and immune systems. This is a gland that sits in the mediastinum superior to the heart. When the baby, a baby is born, if you were to take an x-ray of their chest, you would see that that thymus gland is almost bigger than their heart. It also goes through involution after puberty. This is where we're going to have the site of our T cells maturing to be the most important function of our immune system. It also secretes certain thymic hormones called thymopoietin, thymosin, and thymulin that are going to stimulate the development of some of our other lymphatic organs, as well as initiating and differentiating the activity of our T lymphocytes, what we call our T cells. So if we look here at this picture, we see here's the heart of a newborn, and the thymus sits right on top of it. It is so big because it has to really do a lot of work to begin to develop the immune system of the baby. As you grow to an adult, it's not much bigger than a large walnut. The thyroid gland is the largest gland in the body that is purely endocrine. Some of our glands have more than endocrine functions. These are composed of 2 lobes that are connected by a piece of tissue called the isthmus. It sits just below the larynx. It has a very dense blood supply, so it's a very dark red structure. It has what we call thyroid follicles that are going to make up most of the thyroid. These follicles are going to have a very protein-rich colloid substance in them, very protein-rich with albumin. Inside these follicles, you have follicular cells that are going to line those follicles that are going to be what release our thyroid hormones. It secretes thyroxine, which we call T4, because it has 4 iodines attached to it. And then you have triiodothyronine, which is T3, in response to the release of thyroid stimulating hormone. These 2 different hormones are going to increase the metabolic rate of the cell. It's also going to increase our oxygen consumption as well as heat production. These are going to increase our metabolic appetite as well as growth hormone secretion. We have some parafollicular cells, or what we call C cells, that are going to secrete something called calcitonin. We see this secretion of calcitonin in young children, particularly when we are looking at bone formation. Calcitonin is going to be released with rising blood calcium. This is going to stimulate particular cells called osteoblasts to begin to grab into that calcium that's in our bloodstream and pack it into the bones so that the bones can then begin to grow. So if we look at the anatomy of the thyroid gland, we have our trachea here. We have the thyroid that sits right there on the trachea. We have the 2 lobes of the thyroid that are connected here by the isthmus. On the posterior side of the thyroid gland, we have the parathyroid glands. Usually there are 4 of them. They can be found either as high as the hyoid bone or as low as the aortic arch. So they aren't necessarily always in the same place. Their job is to secrete parathyroid hormone, and parathyroid hormone has a direct effect on our blood calcium and our phosphate excretion. We're going to see that it's going to increase our blood calcium levels by promoting the synthesis of something called calcitriol. This is going to help with the production of vitamin D synthesis. It also increases the absorption of calcium in the bloodstream. It decreases our urinary excretion of calcium, and it also increases the amount of calcium that gets reabsorbed back into the bones to make the bones stronger. Here we can see on the backside of the thyroid gland, we have our 4 parathyroid hormones. The adrenal gland is the next gland, and we can divide the adrenal gland into the adrenal cortex and the adrenal medulla. We have the adrenal cortex, which is going to make up the majority of the adrenal gland, and then the adrenal medulla, both of which are going to secrete different hormones. When we talk about the adrenal medulla, this is about the 10 to 20% of the inside of the adrenal gland. It has both an endocrine and a sympathetic nervous system function. It's innervated by specific sympathetic fibers, what we call preganglionic fibers. And these are going to be also modified sympathetic postganglionic neurons called chromaffin cells. These are going to help stimulate the release of the particular hormones that come from our adrenal medulla, which are going to be epinephrine and norepinephrine. There are some traces of dopamine that can go directly into the bloodstream from the adrenal medulla. The hormones that come from the adrenal medulla are what we call our catecholamines, and they have multiple effects. They can increase our alertness and prepare our body for that physical activity, like our fight or flight response. They can also mobilize a number of high energy fuels like glucose and fatty acids. We can have glycogenolysis and gluconeogenesis by the liver that are going to basically break down glycogen and fatty acids to produce glucose. This is going to increase our glucose levels in the blood. Epinephrine can inhibit the production of insulin so that we can, again, have glucose sparing effects so that our blood sugars, our blood glucose levels stay high. Muscles can use fatty acids to go through gluconeogenesis to produce glucose for their use of ATP, saving that glucose in the blood to go up to the brain. We can also see that the adrenal medulla can increase blood pressure by the release of epinephrine and norepinephrine. It can increase heart rate as well as blood flow to the muscles in the pulmonary system. It decreases digestion and in most cases, urinary production. The adrenal cortex is going to be the outer layer of the adrenal gland. It surrounds the adrenal medulla and secretes a number of different corticosteroids or the hormones of the adrenal cortex. We have 3 layers of the adrenal cortex. We have the zona glomerulosa. This is going to be cells that are going to be arranged in small rounded clusters that are going to secrete our mineral corticoids that are going to release our body's electrolyte balance. One of these mineral corticoids is aldosterone. We have the zona fasciculata. This is going to have cells that are arranged in fascicles that are going to be separated by the capillaries within the adrenal gland. And these are going to secrete our glucocorticoids and our androgens. Then finally, we have the zona reticularis. This is going to be a set of cells that are going to produce a branching type of a network that are going to secrete the glucocorticoids and our sex steroids. So if we look at our mineral corticoids, these are going to be steroids that are going to regulate electrolyte balance. If we regulate our electrolyte balance, we also regulate our water balance. And we do this by releasing something called aldosterone. Aldosterone is going to stimulate the retention of sodium and the excretion of potassium. When we retain sodium, we also retain water. Wherever salt goes, water follows. So if sodium comes into the cell, water is coming into the cell. So our blood volume increases, our blood pressure increases, and we can maintain both blood viscosity and blood pressure. Aldosterone is part of the renin-angiotensin-aldosterone system that helps with fluid management. The glucocorticoids are going to come from the zona folliculata and the zona reticulata, and they are going to be in response to the adrenocorticotropic hormone from our anterior pituitary. We're going to regulate metabolism and glucose and other fuels with these glucocorticoids. Cortisol and corticosterone are going to be the major glucocorticoids, and they're going to stimulate fat and protein catabolism. By breaking these down, we go through gluconeogenesis, which is going to be glucose from our amino acids and our fatty acids. And we're also going to see the release of fatty acids and glucose into the bloodstream. This can also help the body adapt to stress and repair tissues. This cortisol is essentially going to be released in times of stress to manage our stress level so that we don't have any kind of damage caused by the excess stress. It does have an anti-inflammatory effect that can become immune suppressing with long use. If we have too much cortisol or corticosterone being released over a long period of time, this can actually begin to suppress the immune system and can have a counterintuitive effect. Our sex steroids are going to also come from the fasciolata and the reticularis, and these are going to be our androgens and our estradiols. The androgens are going to be our male hormones that are going to set libido. They're also going to play a very large role in prenatal male development. The estradiols are going to be our estrogens, and these are going to be secreted in small amounts by the adrenal glands. And this becomes extremely important when you have women that have become postmenopausal. This release of estradiol is going to be able to sustain adult bone mass and help women to prevent the production of osteoporosis. The pancreas is also what we call an endocrine and exocrine cell. The pancreas has pancreatic islets, and those pancreatic islets are made up of 3 different types of cells: our beta cells, our alpha cells, and our delta cells. Glucagon is going to be secreted by the alpha cells of the pancreas. These are also called the glucagon cells. We're going to release glucagon when blood glucose levels begin to fall between meals. The liver is going to stimulate something called gluconeogenesis, where we're going to take fatty acids and convert them to glucose. We also have glycogenolysis, which is going to take glycogen, break it down into its small pieces of glucose, and increase our circulation of blood glucose by putting this new glucose into the bloodstream. In our adipose tissues, this glucagon is going to stimulate fat catabolism and release some of those free fatty acids that, again, are going to allow for the production of glucose through gluconeogenesis. Glucagon can also be released in response to rising amino acid levels in the blood. This is going to promote that amino acid absorption and provide cells with the raw materials for gluconeogenesis. One of the things that happens with people who are on high protein diets like the keto diet, they produce tons and tons and tons of glucagon. Insulin is secreted by the beta cells or the insulin cells, and this is going to be secreted when we eat, when our blood glucose levels and our amino acid levels are rising. This is going to stimulate the cells in the body to absorb the nutrients and store and metabolize them, which is then going to lower our blood glucose levels. We're going to see the synthesis of glycogen, fat, and protein when we release insulin. This is also going to suppress the use of already stored fuels. So we're using what's available and not going into our stored fuel. The brain, the liver, and the kidneys, as well as the red blood cells, are going to absorb glucose without insulin, but the other tissues are going to require insulin to make sure that blood, glucose leaves the blood, binds to the receptors on the target tissues, and causes that glucose then to go into the tissues. We can then have insufficiency or inaction of our insulin, which can lead to the development of diabetes mellitus. We can also see that the beta cells are going to produce something called amylin, which is going to reduce spikes in our blood sugar by reducing the uptake of nutrients right away. Somatostatin is secreted by the delta cells, and these are going to suppress the secretion of glucagon and insulin. It also is going to inhibit nutrient digestion and absorption, which is going to then prolong the absorption of specific nutrients. This somatostatin works alongside amylin. You can also have the pancreas producing what we call pancreatic peptides, and this is going to inhibit what we call vagal stimulation of the pancreas by that vagus nerve. We can have states of hyper and hypoglycemic issues. Hyperglycemic hormones are going to raise blood glucose concentration. This is going to include glucagon, growth hormone, epinephrine, norepinephrine, cortisol, and corticosterone. All of these hyperglycemic hormones are going to have effect on rising blood sugars. Hypoglycemic hormones are going to lower blood sugars, and these are going to be things like insulin. The gonads are going to be our ovaries and our testes. These are both endocrine and exocrine glands. As the exocrine gland, they are going to produce whole cells, the egg and the sperm. This is what we call cytogenic glands. As an endocrine product, they're going to produce the gonadal hormones. These are going to be like progesterone, estrogen, testosterone. The ovarian hormones are going to be estradiol, progesterone, and inhibin, whereas the testicular hormones are going to be testosterone, some of the weaker androgens, estrogen and inhibin. So if we look here at the ovary, we have the egg here in the center. That egg is surrounded by the granulosal cells. Those granulosal cells are going to be surrounded by something called the theca. The ovary has the theca cells that are going to secrete a particular hormone called androstenedione. This is going to be converted to mainly estradiol by the granulosal cells. Once we have ovulation, we're going to see the remains of the follicle become what is called the corpus luteum. It's going to secrete progesterone for about 12 to 14 days following ovulation to manage implantation and pregnancy if pregnancy should happen. The follicle and the corpus luteus are going to both secrete inhibin. The functions of estradiol and progesterone are going to be the development of female reproductive systems, as well as the physique, including adolescent bone growth. We're also going to see that it is going to regulate the menstrual cycle and sustain pregnancy and prepare the mammary glands for the production of milk. The hormone inhibin is going to suppress follicle stimulating hormone until we go through that process of ovulation. If no pregnancy happens, inhibin will stop, follicle stimulating hormone will be active again, and that follicle stimulating hormone comes from the anterior pituitary. The testes are going to have microscopic seminiferous tubules that are going to be mostly responsible for the production of sperm. The tubular walls are going to contain specific cells called sestanicular or Sertoli cells. We also have some Leydig cells, which are the interstitial cells that are going to be in clusters between the different seminiferous tubules. The testicular hormones are going to mostly be testosterone. These are going to come from the interstitial cells that are going to come from in between those tubules, those Leydig cells. It's going to stimulate the development of the male reproductive system in the fetus and the adolescent changes during puberty. It also is going to be responsible for the sex drive. It sustains sperm production as well. Inhibin is going to come from a group of cells within the testes called nurse cells. This is also going to limit follicle stimulation secretion in order to regulate sperm production. So if we look here, we've got our blood vessels here. We have our seminiferous tubule, which is this large structure here. We have our nurse cells. This is all going to be part of the production of sperm within the testes. We do have some endocrine functions of other tissues and organs within the body. The skin is one of those areas. It produces keratinocytes that are going to convert certain cholesterol-like steroids into cholecalciferol, which is going to use the UV light from the sun to help produce vitamin D. The liver is involved in a number of different hormones. It converts cholecalciferol to calcidiol, which is, again, a precursor to vitamin D. It secretes angiotensinogen to an active form called angiotensin. This is also going to help regulate blood pressure. It secretes about 15% of a protein called erythropoietin. That erythropoietin is going to stimulate the bone marrow to produce more red blood cells. It's also a source of IGF-1. This is going to control the action of growth hormone. This is going to be something that has an effect on growth hormones so that you don't have excess release of growth hormone. You also have a protein called hepcidin, and this is going to produce or promote intestinal absorption of iron. The kidneys also have about 3 different hormones that get released. They convert calcidiol to calcitriol, which is the active form of vitamin D. This vitamin D is going to increase calcium absorption by the intestines. It's going to inhibit the loss of calcium in our urine. It also secretes renin that converts that angiotensinogen to angiotensin 1. We have a converting enzyme in the lungs called the angiotensin converting enzyme that converts angiotensin 1 to angiotensin 2. This is going to cause constriction of the blood vessels, which is then going to raise blood pressure. The kidneys produce about 85% of the rest of our erythropoietin. And again, that's going to stimulate our bone marrow to produce red blood cells. The heart produces something called atrionatriuretic peptide in response to increasing blood pressure. What this does is it decreases the volume of blood and blood pressure by increasing the sodium and water that is output by the kidneys, and it's going to be an antagonist to the action of angiotensin 2. It's going to lower our blood pressure by decreasing the action of the atria of the heart. The stomach and the small intestines are going to secrete a number of enteric hormones that are going to be secreted by some specific cells called the enteroendocrine cells. These are going to coordinate digestion, particularly the motility of peristalsis and the secretion of digestive enzymes, particularly the secretion of cholecystokinin, gastrin granulin, and peptide YY. Our adipose tissues also secrete some hormones. One that they secrete is something called leptin. That leptin can actually have an effect on appetite and cause it to slow. Our bone tissue or osseous tissue will produce something called osteocalcin, which is secreted by our osteoblasts. This is going to increase the number of beta cells, and we're going to then have an increase in pancreatic output of insulin and the insulin sensitivity to the body tissues. It can also inhibit weight gain with the onset of type 2 diabetes. One of the symptoms that will send people to the doctor that gets them the diagnosis of diabetes is unexplained weight loss, and that's because of this osseous tissue. The placenta is also going to secrete certain hormones like estrogen and progesterone. It's going to regulate pregnancy as well as stimulating the development of the fetus and the mammary glands in the mother. Okay, that's the end of section 17.3. We will pick up on the specific hormones and the actions of each of those hormones in the next section.